nuclear thyroid imaging and therapy with Ti-RAD. This lecture is only for teaching purposes. I do not claim any original material. My resources and acknowledgments are in the next few slides. My first acknowledgement and resource is an excellent article that I found on the web by Dr. Sumati Sundaraiya from Chennai, India. And the next is Controversial Issues in Thyroid Cancer by Michael Tuttle, published in Journal of Nuclear Medicine. I used the Ti-RAD Atlas from ACR Thyroid Imaging Reporting Data System. Um, Treatment of Thyrotoxicosis by Igaru and McDougall, Journal of Nuclear Medicine. Radioiodine Therapy for Thyroid Cancer by Perima and Mandel in Journal of Nuclear Medicine, and PET-CT in Management of Thyroid Cancer by Marcus et al. In the American Journal of Rankinology. So let me start by briefly giving you some details about the thyroid and how it uh, entraps and uses iodine, and also how we use technetium. So thyroid gland concentrates iodine, and typically we have two isotopes that we use. Iodine 131 has gone out of favor because of its unfavorable imaging characteristics related to its energy. On the other hand, technetium 99m and iodine 123 are ideal for gamma camera imaging. So I will be focusing on these two agents. Now, pertechnetate is the other agent that I mentioned. Now, iodine 123 has a half-life of 13 hours, energy of 159 keV. 131, on the other hand, is a beta emitter, and it is used for treatment of thyroid cancer and hyperthyroidism. Pertechnetate is a gamma emitter with a half-life of 6 hours, and it has an uptake mechanism based on sodium iodide importer pump, which is similar to iodine. Now, normal thyroid gland weighs about 15 to 20 grams. Isthmus connects the two glands. Pyramidal lobe is a remnant of thyroglossal duct. Pyramidal lobe is enlarged in Graves and Hashimoto's. Follicular cells trap iodine by this symporter iodine sodium iodide mechanism. The trapped iodine is then converted to iodine by peroxidase, and then it is organified. This is a key concept to keep in mind. So organification essentially means that iodine combines with tyrosine and is incorporated into thyroglobulin. Now this is a key concept because um, pertechnetate is trapped like iodide but is not organified. So pertechnetate is an analog of iodine. It is transported to the thyroid cells. It is not organified, so it is not incorporated into thyroid hormones. It is typically used by an IV injection, and peak level is achieved in 15 minutes, plateaus in about 15 to 30 minutes, and it is not retained in thyroid after 30 minutes. So imaging is performed ideally between 20 and 30 minutes. Um, Iodine 123 has a half-life I mentioned of 13.2 hours. It emits gamma rays. It is ideally suited for gamma camera imaging. It gives much less radiation compared to iodine 131. Because it is organified, it leads to a better retention and better images. So iodine 131 is a beta emitter. It decays by beta minus decay. It has an energy of gamma photons of 364, which is not optimal, leading to penetration through the septa. T-half of 8 days, long T-half, and obviously it gives high radiation dose, so it's not ideal for routine thyroid scan. It's gone out of favor now. Poor image quality because we have to give low doses to reduce the radiation. Now we use this for a number of purposes. We can use it for uptake calculation, for whole body imaging in the patients who have thyroid cancer, for residual thyroid tissue evaluation, for metastatic disease, for treatment, and for Graves' disease treatment, toxic nodule treatment, and obviously thyroid cancer treatment. Um, so, radioactive iodine uptake is helpful in the differential diagnosis of thyrotoxicosis. The uptake is elevated in Graves' disease, whereas it is reduced in thyroiditis. Now, uptake is done before for iodine 131 31 therapy given for Graves' disease, because we want to see the uptake values, and based on that we kind of decide what dose to give. And I will be talking about this later on in the later part of the lecture. So a known amount of radioiodine is given orally, and then the percentage taken up by the thyroid is measured by a thyroid probe, and uptakes values are obtained at 4 hours and 24 hours along with scintigraphy. Now, count measurement at 4 hours represents uptake phase, whereas at 24 hours count uptake signifies the organification phase. Um, some do's and don'ts related to the procedure. It is a good idea to stop thyroxine for 4 weeks, T3 for 2 weeks. If patient is on any type of anti-thyroid medication, iodine-containing medication, cough medication, food, seafood, they interfere with thyroid uptake values, so they need to be stopped. If the patient has any recent iodine contrast CT scan, then we don't want to do the examination at that point, and we need to have a gap of a few weeks. Typically, the patient is fasting for 4 hours before ingestion of radioiodine to ensure good absorption, and the uptake values normal are 5 to 15% at 4 hours and 15 to 35% at 24 hours. Now, chronic thyroiditis, the uptake at 2 to 4 hours is greater than at 24 hours. So that is suggestive of peroxidase enzyme deficiency. Graves' disease, 24-hour uptake is greater than the 2-hour or 4-hour uptake. Percentage radioactive iodine uptake are elevated in conditions like Graves' disease, toxic adenoma, toxic multinodular goiter, or iodine deficiency. If the patient is recovering from thyroiditis in neonates, in case of dysharmogenesis, and after stopping anti-thyroid medication, and the uptake values are decreased if the patient had an iodine load, factitious thyroiditis, hypothyroidism, and ectopic thyroid. Now, you can calculate these the same thing with the pertechnetate. I do not favor pertechnetate, but it is cheaper. The advantage is that it is uh, it is low cost and can finish the study in a short duration of time. Normal uptake is 0.2 to 4%. Um, this is an example of a pertechnetate scan. This is a normal thyroid. There are two markers that have been placed, one on the chin and one on the suprasternal notch. So uniform uptake, and here you are seeing uptake in the salivary gland. So this you need to be aware of as a part of its normal biodistribution. Um, a word about hyperthyroidism and thyrotoxicosis. They are not synonymous. Thyrotoxicosis is a hypermetabolic clinical syndrome because of high T3, T4. Um, so subacute thyroiditis and thyroiditis factitia, they cause thyrotoxic because of the release of stored thyroid hormones into the circulation. Hyperthyroidism, on the other hand, is a thyrotoxicosis because of hyperfunctioning thyroid gland or accelerated thyroid hormone production and secretion. So it is not being released. Here it is because of increased production and secretion. And thyrotoxicosis increased T3 and T4. So mindful of the difference. Now, Graves' disease, a pertechnetate scan showing you increased uptake and uniform uptake in both the glands, a little bit of uptake in the isthmus, again, chin and suprasternal notch markers, uptake in the salivary gland. Um, Again, an example of the Graves' disease, elevated uptake at 24 hours. Here is an example of a toxic nodular goiter. You see, if you compare this entire gland and this part of the gland, you see how intense the uptake is. It is high uptake here. And so the gland itself is kind of heterogeneous. Again, you see intense uptake here, but there is heterogeneous uptake here. So there are hyperfunctioning nodules, and they suppress the rest of the uh, gland. Now here's an example of a subacute thyroiditis where you are seeing uptake in the salivary glands. Uh, these are the two markers for the chin and the suprasternal notch, and you are expecting uptake here in the thyroid, and you see hardly any uptake. But this patient presents with thyrotoxicosis, so obviously a low uptake or no uptake uh, in the gland, along with symptoms of thyrotoxicosis, would suggest subacute thyroiditis. Something to keep in mind. How do you differentiate between Graves versus toxic multinodular goiter? In Graves, you have a uniform increase uptake. In if you were to do a calculation with pertechnetate, the uptake would be greater than 4%, and if you were doing a radioactive iodine uptake, it would be 50 to 80%. Um, so in some cases, obviously, Graves' disease can be superimposed on a non-toxic multinodular goiter. All right. So toxic multinodular goiter or plumber's disease is, you'll find inhomogeneous tracer uptake, and there would be high uptake in the hyperfunctioning nodules, and the rest of the gland would be suppressed. And the uptake values are moderately elevated or maybe in the high normal range. Now, what about the autonomous functioning thyroid nodule? Basically, here one nodule is working independently of TSH, and it is able to absorb avidly the radioactive iodine or pertechnate, and it suppresses the rest of the gland. So you will see one high area of increased uptake and the rest of the gland being not visible or hardly visible. I will be briefly talking about the treatment. So the decision to treat the autonomous nodule depends upon the size and degree of function of the nodule and the patient's age. I will be touching these topics a little bit later. Here is an example of a pertechnetate scan. So you see that the right thyroid lobe is kind of missing. This entire left lobe has this high uptake, and now we have the chin and the suprasternal notch, and here you see how this is suppressing the entire rest of the gland. Now, Hashimoto's disease is an uncommon cause of thyrotoxicosis. During this thyrotoxic phase, the uptake is elevated, radioactive iodine uptake is elevated, and scan shows diffuse increased uptake, which is similar to Graves' disease. This is an example how intense uptake is seen in both the glands, both the lobes of the thyroid, and with the in a patient who has an elevated TSH levels. All right, now what are the conditions where there is suppressed thyroid uptake? So subacute thyroiditis is most common cause of thyrotoxicosis with decreased percentage uptake. Also remember that it depends on the stage of the disease and the damaged gland's ability to respond to endogenous TSH stimulation. So the patient's hypothyroidism would resolve in a few weeks or months. Um, and the uptake could be suppressed in the entire gland, or it could be patchy or regional. And so you may have variable appearance in the severe, depending on the severity of the thyroid damage, and scan may show inhomogeneity or may show areas of focal or regional hyperfunction. So, what happens in Hashimoto's or chronic autoimmune thyroiditis? There is autoimmune destruction with lymphocyte infiltration, and most common of all thyroid disorders, it affects all ages, and normal thyroid follicles are replaced by lymphocytes and fibrous tissue. There is eventual reduction in the thyroid function, leading to impairment of hormone production. And on the scan, you will see an enlarged gland with increased uptake, a pattern which is similar to Graves' disease, and it is due to compensatory rise in the TSH secretion, and this stimulates the thyroid to synthesize more thyroid hormones. So there is going to be diffusely increased uptake and radionuclide activity. All right, now again, I mentioned the same thing, and so one thing to remember is there is also a variety which is postpartum thyroiditis, which is an autoimmune disease like Hashimoto's, happens in postpartum period and would show fluctuations as thyrotoxicosis followed by hypothyroidism. Now, a brief word about what is a hard, cold, and a warm nodule. So, anything which is low in uptake values compared to the rest of the gland, meaning photopenic is cold, one which is higher uptake than the rest of the gland is hot, and one which is equal to the rest of the gland is warm. So, typically, if you have a cold nodule, then you have to worry about it. But most of the clinically or incidentally detected thyroid nodules are benign. They are evaluated with FNAC, core biopsy, and serum TSH. And thyroid scintigraphy is seldom used, but it has its uses, and I will briefly touch upon that in the next couple of slides. So here is an example of a cold nodule. Cold nodule. See how there is normal uptake, and then there's this cold area here. Same thing here, here, and here. So cold nodule. Next slide. So mild uptake in the rest of the gland, and this area is very hot. So hot nodule. Hot nodules by definition are benign. So 80 to 85% of the thyroid nodules are cold, and 10% of these are malignant. So a dominant cold nodule in a gland with multiple nodules should be investigated as a single solitary nodule, and there is a probability of 2 to 10% in terms of malignancy, and so this needs to be investigated, and if needed, be excised. So in hard nodule, on the other hand, very rare incidence of cancer. So typically, by definition, a hard nodule is a benign lesion unless proven otherwise, which we normally don't biopsy. So scintigraphy has an adjunctive role, and you can use you can use scintigraphy to determine the functional status of a nodule in a patient with biochemical or clinical evidence of hyperthyroidism, and sort of there may be no need to do FNAC in a hard nodule. So you can determine the functional status of a nodule, whether it is um, a follicular neoplasm by FNAC and biopsy. Now, in case of a goiter without a dominant nodule, scintigraphy can be used to select a potential biopsy site. So that's the use of scintigraphy. Another use could be substernal extension of a nodule or goiter. You can also use it to detect ectopic thyroid tissue. Now, retrosternal goiters are associated with palpable enlargement of the cervical thyroid and diagnosed clinically if the lower border of the goiter cannot be felt. To confirm, you can do a X-ray chest or a CT scan, and then you can do an iodine 123 scan. You can certainly use MRI, or these can be incidentally discovered on MRI or CT scan. So here's an example of a goiter which is going down. So this is the suprasternal notch, and as you can see, the gland is quite enlarged and is extending below the suprasternal notch. An interesting example of a hot nodule or uptake in a sesame B scan. Um, so, I mean, it is not necessary that anything that is picked up on sesame B is malignant, but certainly if you are doing a cardiac study and it is picked up, you have to pay attention to it. Here is an example of a FDG PET where you are seeing uptake in the thyroid as well as uptake in the neck lymph nodes. Um, this is the same patient, another image showing you uptake in the left thyroid lobe. So this turned out to be a papillary cancer. Um, so I'm going to touch briefly about the congenital hypothyroidism. Now it has a wide spectrum. One can be that the gland is underactive, and the other variety could be that it may be a complete absence of gland, and in between you have many other causes or problems. So congenital hypothyroidism is the most preventable cause of mental retardation in childhood, and uh, and so obviously you can test by blood the TSH values, and based on that you can come to some conclusion, but the clinical and biochemical parameters would fail to distinguish between an ectopic or hypoplastic thyroid, athyrosis, dysharmonogenesis, and transient hypothyroidism. So thyroid dysgenesis is the commonest cause, 80 to 85%. 10 to 15% are because of dysharmonogenesis, and then among the patients who have dysgenesis, you have a majority, up to 67% because of ectopic thyroid, one third are because of thyroid agenesis. All right, so Now, if you have a genetic defect in the biosynthesis that leads to, most common is the peroxidase enzyme deficiency that leads to dysharmogenesis. And once the diagnosis is established, there are further investigations to be done. How does scintigraphic help? Well, of course, if you have no uptake in the thyroid gland, then it tells you there is no gland. Um, uh, well, you can do an ultrasound. You may not find a gland, and you can do a pertechnetate scan, and you may not find any uptake there. It can be in an ectopic location, and it can be a goitrous hypothyroidism because of dysharmonogenesis. So scans should be done ideally before giving a replacement thyroxine. Um, and I mentioned about the difference between pertechnetate and iodine trapping. So remember, if you have to differentiate between a gland which is physically present but has dysharmonogenesis or peroxidase enzyme deficiency, you may do a radioactive iodine uptake, radio iodine scan, and you may find uptake. But if you were to do, I'm sorry, if you were to do a pertechnetate scan, you would find uptake. Whereas if you were to do an iodine scan, you would not find any uptake. That would tell you that there is a problem with the gland's ability to trap and organify iodine. And that is most commonly because of peroxidase deficiency. Here is an example of a person uh, where we did a pertechnetate scan and there's no uptake in the thyroid. So whether it is because of a ectopic or because the gland is not um, present, so ultrasound showed no evidence of a thyroid gland. All right, this is an example of a person normal thyroid uptake by a pertechnetate scan. So that means it is in a normal location, avid uptake. So this would be uh, consistent with dysharmonogenesis. So I mentioned that normal thyroid uptake on PTC scan means the thyroid gland can trap, but if this was to be repeated with an iodine 123, you would find that there is no uptake, and that is because the gland is not able to organify the iodine. Um, so a little bit about the congenital anomalies, how you need to scan and what you need to do, and I kind of have already talked about it, so I'm not going to discuss this anymore. I'm going to talk briefly about thyroid cancers. So there are two varieties. One are well differentiated, and then of course is the variety which is poorly differentiated, and the other ones. So the thyroid cancer originates from follicular, parafollicular thyroid cells. Papillary and follicular are the well differentiated. Medullary, uh, C or parafollicular cells which produce calcitonin. Anaplastic is poorly differentiated, and you can use ultrasound and ultrasound guided FNAC or co-biopsy for diagnosis. MR or CT would help in terms of the extrathyroidal involvement. Whole body iron 123 or 31 is not useful for preoperative surgical staging of thyroid malignancy, but after thyroidectomy, whole body is done to evaluate for any locoregional disease and distant metastases. And whole body is routinely performed after a radioactive ablation at the interval of 6 months or a year to see any recurrent nodal mets in the neck mediastinum, especially if the thyroglobulin is elevated. Now, in patients who are low risk, a post-ablative whole body iron scan may not be necessary if the thyroglobulin is not detectable or ultrasound is normal, and ultrasound is normal. So here's an example of a post-total thyroidectomy uptake in the neck in the residual thyroid tissue, and additionally you see there are neck nodes that are positive. Now here's an example of a whole body scan. You see there is this septal penetration and the star imaging artifact. So there is a residual thyroid tumor, and then of course there are multiple bony metastatic lesions. A brief word about FDG and thyroid cancer. The FDG uptake has an inverse relation with the sodium iodide symporter, and high FDG and low iodine uptake uh, is seen in dedifferentiated tumors, and it indicates poor prognosis. So if you do a FDG PET and there is high uptake, um, and if you were to do whole body iodine 131 and there's no uptake, This would go along with it, dedifferentiated tumor with a poor prognosis. On the other hand, if you have a high iodine uptake, these people are likely to respond very well to iodine treatment. Patients with distant metastasis with negative iodine scan finding and positive FDG uptake are treated with tyrosine inhibitors. So these are some of the new concepts. And FDG PET CT is useful in patients with papillary thyroid cancer with rising thyroglobulin level and a negative iodine 123 scan. FDG PET is useful in patients with Hürthle cell and aplastic thyroid cancer. Um, in the past, I'm going to talk briefly about the controversies. In the past, everybody who had intrathyroid or papillary thyroid cancer was subjected to high intensity treatment, that is total thyroidectomy, then with or without neck dissection, and then radioactive iodine therapy, prolonged TSH suppression, and then follow-ups. The new guidelines by ETA and the cancer NCCN allow for low intensity treatment. That means you can observe or thyroid lobectomy without the need for radioactive iodine therapy or TSS suppressive therapy in a selected group of patients. Now, I want to talk briefly about a few. I want to talk briefly about hyperthyroidism, the treatment approaches. One is a fixed dose approach, which is 5 to 15 millicuries, and obviously higher dose if the gland is larger and uptake is low. The other is based on a calculation. We use a formula. Actually, there are two formulas. One is the based on the gland size and uptake. So Z times the size of the gland times 100 divided by the percentage uptake. This is one formula. The other is based on size and uptake. So you have Z multiplied by the size of the gland times 100 divided by the percentage uptake. And so according to one of my references, the authors use about 160 microcuries per gram. Although in the literature, the dose is 100 to 200 microcuries per gram of the thyroid tissue, thyroid size. Um, Autonomous nodules and multinodular goiter, you can use up to, for autonomous nodule, 10 to 30 millicuries. For toxic multinodular goiter, you can use a dose of 200 microcuries per gram. And again, the dose is calculated from the 24-hour uptake and volume, which is determined by the ultrasound. When the uptake values are low, the values can be increased with recombinant TSH. All right. Now, I did mention that these days, not everybody is being subjected to the high intensity therapy, and all patients who have some remnant tissue in the past after thyroidectomy were ablated. But now there are people who are of the view that if the patient receives the benefit to ablation is that um, if the thyroglobulin is undetectable, it is straightforward to monitor the thyroglobulin increase in the future. So that's the that's the argument in favor of remnant ablation. But if the patient does not receive ablation and thyroglobulin rises in the future, then you are in a dilemma, because you don't know whether it is because the remnant has regrown or is that because of the recurrent tumor. But recent studies have shown that patients who have very low or undetectable serum thyroglobulin in a sensitive assay at 1 year after treatment have a very low recurrence rate. So low risk patients in whom remnant ablation is indicated, there is a strong support that a much lower dose may be as effective as a higher dose, which is 1.1 gigabecquerel versus 3.7 gigabecquerel. So I'm quoting some of these selective um, points from some of the references I quoted in the beginning of this lecture. Um, Patients who have undergone comprehensive resection of extensive locoregional disease without known gross residual tumor, patients' successful adjuvant treatment will prevent or delay the development of clinically detectable disease. And in these situations, uh, if post-operative adjuvant therapy will have remnant ablated with the treatment, but the primary goal of therapy is adjuvant. Now, radioactive iodine therapy is the administration of radioactive iodine in an attempt to destroy known or suspected active macroscopic viable malignant cells within the patient. And so here the dose range is 1.1 to 5.6 gigabecquerel. Um, who so according to the ATA and National Comprehensive Cancer Network guidelines, who are the patients who do not require radioiodine therapy? If a patient has less than 1 centimeter papillary small or less than 2 centimeter for follicular or a Hurtl cell thyroid cancer, which is intrathyroidal tumor without any nodal involvement or vascular invasion, and the low post-surgical thyroglobulin levels. So these patients do not require iodine 131 therapy. Patients who have multifocal papillary thyroid cancer but no other risk factors do not benefit from remnant ablation. And patients in whom radioactive iodine is definitely recommended are those who have larger than 4 centimeter primary tumors or gross extrathyroidal extension. So at least these are the two subgroups where you have a clear-cut uh, uh, answers in terms of what should be done, but there is the gray area where the patients who have, say, a size between 1 and 4 centimeters, what to do with those. So at least in these cases we are very clear cut that they do not require radioactive iodine, and this group of patients more than 4 centimeter does require radioactive iodine treatment. So anybody who's with low thyroglobulin and stable serum thyroglobulin, you can follow on a conservative basis. If there is high serum thyroglobulin or if it is rising, then an empiric therapy may be indicated. Some patients benefit from this therapy, some do not. And obviously, there is controversy in this regard. This is an example of a patient who underwent multiple therapies. Here you are seeing uptake in the lungs following radioactive iodine therapy reduction, but still there is uptake, and then following another therapy, no uptake in the lungs. What is the flip-flop phenomena? And I want to explain that FDG and thyroid cancer, the flip-flop phenomenon. So in well-differentiated thyroid cancers, which are slow-growing, FDG is negative. That means on a PET study done with FDG, in a well-differentiated thyroid cancer, you may not find any uptake, um, and that is because they are FDG negative. So there is a role for PET-CT in management of patients with differentiated thyroid cancer, which is limited to post-operative follow-up. Now, 4 to 7% of patients initially present with distant metastasis, and here PET is not indicated. But remember, FDG PET does not provide information beyond that yielded by ultrasound for pre-op assessment of thyroid cancer. Um, but it has high sensitivity and specificity in patients who have distant metastasis. Um, if there is incidental uptake of the thyroid, incidental uptake of FDG on in the thyroid, what to make of that? So if there is diffuse uptake, it is most likely because of thyroiditis, whereas it is due to activated lymphoid tissue, whereas focal uptake in the thyroid gland is considered to be more important, and most commonly it is because of a thyroid cancer, and so that needs to be taken seriously, and the risk of malignancy in a incidental focal thyroid uptake has been reported as high as 36%. Now, because there is a significant risk of thyroid cancer, a further workup is indicated with ultrasound and biopsy. Um, Three conditions in which outpatient therapy can be arranged. I was talking about the thyrotoxicosis treatment, and obviously, if the patient has a malignancy, you have to admit the patient. Whereas if the patient has thyrotoxicosis, and um, if no adult will be exposed to more than 5 millisievert, you can use iodine 131 therapy as an outpatient, and patients can be released when the administered dose is less than 1.22 gigabecquerels or 33 millicuries. So only patients who get this therapy whether they are hyperthyroid, i.e. thyrotoxicosis, or for remnant ablation. If you're going to use this dose, you can use this dose for outpatient therapy. And if the emitted radiation is less than or equal to 7 millirem per hour at 1 meter, you can use the outpatient treatment for these patients. Again, back to the flip-flop phenomenon, and after surgery, a substantial number of patients have residual or metastatic disease which is not radioactive, iodine avid. So in that situation, PET-CT with FDG has emerged as a tool um, which is not demonstrable. I mean, the recurrent or metastatic disease which is not demonstrable by other imaging modalities. Um, and particularly if the thyroglobulin levels are high, there is a negative whole body scan. PET has a role. PET meaning FDG PET has a role. As the thyroid cancer cells de-differentiate, meaning as they become poorly differentiated, their radioactive iodine uptake goes down, but their glucose metabolism increases. So you will find, well, this finding is not always present, but this pattern of alternating pattern of iodine 131 uptake versus FDG uptake. So if the tumor is well differentiated, it is likely to pick up iodine, but not FDG. On the other hand, if the tumor is de-differentiated or poorly differentiated, it is more likely to pick up FDG, but not iodine 131. So that is what is called the flip-flop. Hurthle cell and medullary thyroid cancer. Now, PET-CT has a high diagnostic accuracy, particularly if the thyroglobulin levels are high. Now, in this particular Hurt cell thyroid, it's an aggressive tumor, high risk of metastasis, very poor prognosis compared to the differentiated thyroid cancer. This particular variety of cancer is unable to concentrate iodine 131, but it is FDG avid. So, this is one variety where PET is useful. And it is useful in accurate localization because surgery and external beam therapy may be beneficial. Medullary thyroid cancer is an aggressive tumor treated with total thyroidectomy and neck dissection, but 50% have persistent or recurrent disease. And PET, FDG PET has been found useful in patients who have a problem of recurrence, which is shown by increasing calcitonin and CEA levels. Anaplastic thyroid cancer is by definition a differentiated, rapidly growing, aggressive tumor with more than 75% having local invasion and 50% having distant metastasis, older age group, faster growth, extensive local invasion, and despite aggressive treatment, poor survival. Most common metastasis is to the lungs, additional bone marrow, and brain. And 50% of these patients have a history of multinodular goiter, and about 20% have a history of differentiated thyroid cancer. So this cancer, which was well differentiated, sort of changed and became de-differentiated, and ultrasound, CT, and MRI have a role in defining the primary tumor extent as well as um, the distant metastasis. So I mentioned about the role of PET and what it is useful for. I'm not going to go more, but PET can also be useful in stratifying patients. So those who have low FDG uptake to start with have a favorable prognosis, even if they are iodine refractory disease. Um, what are the side effects of iodine 131 therapy? Well, there is radiation thyroiditis, so you can give anti-inflammation and anti-inflammatory drugs, maybe steroids. A thyroid crisis is a problem in thyrotoxicosis patients. Long-term risk, well, there was a concern about cancer, but that has been found that it is not really a big concern, and also increased risk of any abnormalities in children. Offspring has not been found. I'm going to talk briefly about the Ti-RADS. This is from the ACR website. Um, so I will talk more about the variety and the different uh, classifications. So the Ti-RADS recommend FNA for highly suspicious nodules which are 1 centimeter or larger. and the Ti-RAD threshold for mildly suspicious is 2.5 centimeter, and the moderately suspicious nodule 1.5 centimeter. This is different from the AT and Korean Society of Thyroid Radiology. Now, nodules that are cystic or almost cystic, they don't need any further investigation. They're universally benign. Now, spongiform architecture is benign regardless of other features and echogenicity. Mixed cystic and solid combines the predominant solid and cystic. Now, in this type, solid component has more importance than the overall size of the nodule. So proportion of solid versus cystic determines where to biopsy. Now, solid material that is eccentric and has an acute angle with the nodule is suspicious. Um, and then, of course, we talk about other suspicious characteristics like decreased echogenicity, lobulation, and punctate echogenic foci. If there is flow in a solid component, that is definitely suspicious. Now, echogenicity of a nodule relates to the relative in relation to the adjacent thyroid tissue. Shape taller than wider is insensitive but highly specific indicator of malignancy, and to keep in mind, if a nodule is taller than it is wider, highly suspicious. The concept of halo has been given up, ill-defined if the nodule is not well-defined. Lobulated or irregular margin refers to a spiculated or jagged edge with or without protrusion into the surrounding parenchyma. Now, extension beyond the thyroid border is extensive. Um, Extensive extrathyroidal extension is characterized by frank invasion of adjacent soft tissue or vascular structures. This is a highly reliable sign of malignancy and an unfavorable prognostic sign. Here is an example of a solid right nodule which has a few cystic components, but it is not a spongiform type. Here is an example of how we measure, and here's the transverse measurement. Here's the width, here's the length. Um, so this is wider than it is taller. Um, all right, so this is an example of a cystic nodule, primarily a benign process. Here is an example of a spongiform. So there are tiny cystic spaces. This is a benign finding. Benign, nothing to do anything further about. So spongiform, small cystic spaces. Now, the next is solid or almost solid, where you see how this entire nodule is more or less solid except for this little part. This is completely solid, and so that is suspicious. Mixed cystic and solid, where you have some components which are solid like this one, and then you have the cystic component. All right, next, echogenicity. This is anechoic, predominantly cystic, benign, predominantly hyperechoic or solid. This is in relation to the rest of the gland. So this is the normal gland. This is hyperechoic, increased echogenicity. Um, isoechoic, this versus this versus this, similar to the rest of the gland. So isoechoic. Hypoechoic, when it is lower than the rest of the gland. Here is an example of very hypoechoic, like this one. It is less than the rest of the gland. All right, next is taller than wide. Here is an example. This is tall, this is the width, so this is taller than the width. Obviously a suspicious finding for malignancy. This is wider. See, this is the width, this is the height. So this is likely to be a benign, but at least not a suspicious finding. The margins here are smooth, very nice margins. Next, ill-defined margins. I mean, it's hard to sort of see. You can see some here, but not so well here. You can kind of see it, but you're not so sure about it. Again, sort of ill-defined. Um, Next, irregular. See, there is some irregularity here. So that's where this is an irregular margin. Lobulated is, sort of protrusion. You can think of about this as a protrusion or microlobulated. And then here is a extrathyroidal extension, how the tumor is extending out. So here's the thyroid, and see how this is extending out of the thyroid margin. So this is certainly quite a suspicious finding. Um, Echogenic Fossae, this is a comet tail. It is a type of reverberation artifact, and typically it is a benign finding. Peripheral calcifications, these are in the periphery of the tumor, nodule, and it may not be contiguous, but generally involves the majority of the margin and dense enough to obscure the central components of the nodule. All right, here's an example of a macrocalcification that are large enough to cause posterior acoustic shadowing. On the other hand, you see how this is a peripheral calcification. Here it is kind of very solid appearing with acoustic shadowing. Here is an example of punctate echogenic foci, but these are not comet tail artifacts. So I want to draw your attention to comet tail. See how these are like little echogenic foci with a little tail behind it, like a star with with a comet and its tail. Now here you have an example of these punctate foci, but there is no tail. Uh, Usually they have no tail. So these are the classifications of Ti-RAD. So essentially, I want to emphasize that when you are doing nuclear imaging for thyroid, these are some of the issues and controversies and things to think about.